Good evening.
Good evening.
We don't have much time. I want to leave time for our speaker to have all the time that she needs. So a story that would ordinarily take me 15 or 20 minutes to tell, I'm going to try to tell you in 3 minutes or less. You think that's a challenge? You think I can do it? What do you think? Okay, so let me do it. I am known as the Story Songbird Woman. I want to give thanks for our musicians that just came. Give you another round of applause.
Okay. I wrote
And
it
they're
down.
part of the Eugenia Collective as well, which was a business collective that also Dr. Emma's part of, and Albuquerque, and myself, where people who have entrepreneurial aspirations to improve their businesses were guided by the fearless leader, Nehemiah Pickett, of the Office of Equity in Albuquerque, with what, about 25 people in the group that we started off with, and maybe we ended with maybe 18 that graduated or so. And we were given these wonderful carvings that were our words from Ghana. Wasn't that beautiful? So I've been blessed to be part of the program and try to improve the work that I do under Ms. Marty's House of Colors, through which I offer tutorial services, entertainment, singing, dancing, acting, and support for people who work to speak English and looking toward opening a cultural art.
And today I'm going to talk to you on empowering communities through health education, the role of technology and local engagement. Most of it is going to come from my experience. And since I have very little time, I'm going to sort of rush so that you'll be able to ask me questions. So, presentation outline is as shown. We're going to introduce this topic and look at African health landscape. Then we'll look at neglected tropical diseases because that's what my expertise is. We'll look at African health challenges, health education landscape in Africa, barriers to health education in Africa, significance of community empowerment in public health education, strategies for effective empowerment, leveraging technology for health education, importance of local engagement in health education. We'll look at some case studies, and integrating technology in local engagement to look at some case studies, and then we'll conclude. So to introduce this topic, there are keywords. Health is a keyword. Empowering community is a keyword. So we'll start with health. We have to understand the term health. Health, according to the World Health Organization, is not merely an absence of disease. It's a state of complete physical, mental, and social well-being. The word health means wholeness, being whole or sound. And health encompasses physical health, your mental health, your social health, as well as your spiritual health. All these come together to determine the wholeness of your health. So an individual's health status is dynamic and varies from person to person, even in similar situations. A person's health is affected by a wide range of factors, including genetics, lifestyle choices, environmental conditions, culture, and access to health care. So promoting health through health education is a collective responsibility, which involves individuals, communities, and governments working together to create a supportive environment where everyone can thrive. Good health is the foundation of a good life. It enables people to work, enjoy hobbies, form relationships, and live long. So let's take a brief look at the African health landscape. The health indicators, there are 4 health indicators: communicable diseases, non-communicable diseases, maternal, newborn, child, adolescent health, sexual, and reproductive health. As a public health parasitology, what I'm going to talk about is going to be centered on the communicable diseases. And under that communicable diseases, there are a set of diseases we call neglected tropical diseases. So I'll take you to neglected tropical diseases. And these are ancient diseases of poverty, which impose a devastating human, social, and economic burden on more than 1 billion people worldwide, predominantly in tropical and subtropical areas, among the most vulnerable marginalized populations. This is according to the World Health Organization 2030 roadmap for NTD control. And there are a diverse set of 21 diseases and disease groups that belong to this group of NTDs. Characteristics of the NTDs. Poverty is the key thing, the first thing. It occurs on people who are very poor, with limited access to healthcare facilities and available interventions. Another characteristic is that there are poor infrastructures, including clean water and sanitation facilities, and very poor healthcare facilities. And then another factor there is ignorance, culture, and behavioral factors that support the sustenance of these diseases. And the final one is the conducive environmental factors that support the transmission and sustenance of these diseases. And let's look at the diseases that belong to this group called the NTDs. We have the worms, the helminth NTDs. We have the protozoans. Helminth and protozoans are parasitic. They're parasitic organisms. Now, we have viral NTDs. We have the non-infectious disease conditions. That is, and then we have the parasitic NTDs. We have bacterial NTDs. We have the fungal NTDs. Amongst all of this, in the whole of Africa, all these NTDs occur in Africa, with the exception of Chagas disease. Chagas disease is also known as American trypanosomiasis. But every country in Africa is affected by this neglected tropical diseases. And looking at the map on my right, the red color depicts countries with more than 8 NTDs. The color orange depicts countries with 7 NTDs. The color yellow depicts countries with 6 NTDs. The color blue, deep blue, depicts colors with 5 NTDs. And the light blue color depicts countries with, you see that light blue, there are 4 NTDs present in the color. And the ones that are cream colored, countries that are cream colored, they have less than 3 NTDs present. So I looked at the records of the New Mexico electronic disease surveillance system. And I found there in the record for 2025, as of June 2025, there is only a case, one report, third case of cysticercosis, which is from Chinyere Ukaga. Chinyere Ukaga is tapeworm. It's tapeworm. And a tapeworm that is gotten from pork. Then you have 13 cases of dengue fever. Dengue fever is transmitted by mosquitoes. And you have 12 cases of rabies. But the rabies are rabies in animals, not in humans. So let's take a look at the health challenges in Africa. The African health landscape is diverse and complex, and is shaped by a mixture of opportunities and persistent challenges. While many African countries have made significant progress in health outcomes, much of the continent continues to be defined by inequities, infrastructure gaps, and disease burdens. The natural environment also, the extreme weathers with climate change, impacts negatively on the health of many African regions. And some of these burdens that persist in the African countries include the burden of communicable diseases. Africa is still battling with a very high rate of infectious diseases, the big 3, malaria, HIV, tuberculosis, as in addition to the NTDs. Then there is a rise of non-communicable diseases in Africa, and these are the chronic diseases such as diabetes, hypertension, cancer. They are rising every day due to urbanization and lifestyle changes. There are still maternal and child health challenges. there is high maternal and infant mortality. It persists, especially in the rural areas. Just last week, a colleague of mine, the sister, died at childbirth. So it's happening. But most of these deaths are preventable with better access to prenatal care and skilled birth attendants. Another challenge is health infrastructure and workforce shortages. In most African countries, especially we're talking about the rural areas, there are insufficient hospitals, clinics, equipment. They are insufficient. And likewise, there is a shortage of healthcare workers. And then we cap this up with the impact of crises and emergencies. Africa remains vulnerable to health crises like Ebola outbreak. Right now, Ebola outbreak is in Uganda. In Congo. Right now, as we speak. And Africa was vulnerable to other conflicts-related health breakdowns. So let's look at, remember our topic is empowering communities through health education. So we've looked at the health. Now let's look at health education landscape in Africa. Plays very key roles in tackling the unbounding health challenges and improving the well-being of many African diverse. Health education empowers individuals to make informed decisions about their health through clear understanding of the disease causation as well as prevention. For instance, in Africa, we know about malaria prevention. There are so many interventions sent down for malaria prevention, like treated bed nets. But if you come to communities in Nigeria, in other parts of Africa, each family may have up to 6 bed nets, but nobody is sleeping under these bed nets. The bed nets they are used for fishing, they are used to cover their vegetable gardens, to prevent bugs from eating their vegetables. Now, health education has also taught hand wash and where there must be hand wash and other hygiene practices. This has significantly reduced disease burden. Through health education, promoting maternal and child health, safe delivery practices, breastfeeding, and immunizations are ongoing. And through health education, there is combating of misinformation. Health education counters myths and promotes trust in healthcare system. When interventions are sent to Africa, especially vaccines, without health education, nobody will take it because there will be misinformation that the vaccine that has been introduced is one that will make them sterile. This is why there is need for health education. And behavior and early reporting of cases. What are the barriers to education in Africa? Language and literacy barriers. There are over 20,000 different indigenous languages across the continent, even within region. Even within Nigeria, there are more than 200 languages in Nigeria, just Nigeria. And there are still very poor communities with very low literacy rates within the regions. Another barrier to health education is cultural beliefs, practices, and stigma. Some communities hold certain beliefs that attribute certain health conditions to forces other than disease-related, and thus they rely on traditional healers. This is a very delicate ground that requires education in order to gain trust for effective health education. Another barrier is inadequate resources, limited healthcare infrastructure. With the declining economics everywhere globally, there is increasingly limited availability of trained health educators, teaching materials, as well as infrastructure without external funding. Another barrier is gender inequality and poor access to information. In many areas, women have less access to education and health information, despite being the primary caregivers. This is oftentimes related to cultural beliefs. And then finally, a major barrier is poor governance and political will. Often many African leaders don't give much attention or they don't budget much for health education. So we look at community empowerment. While Africa can be credited with significant strides in combating many major diseases. However, a purely curative approach remains unsustainable due to many factors, including behavioral factors. Something is cured and the behavior of the person goes back and gets reinfected. Cultural, socioeconomic, and environmental factors that promote the sustenance of such diseases. True progress lies in shifting the paradigm towards prevention, a strategy that is most effectively executed by empowering communities themselves. So health education in this context is not merely the dissemination of medical information, rather it becomes a powerful transformation tool that equips individuals with adequate knowledge, skills, as well as confidence to take control of their well-being, thereby building a more resilient and self-reliant society. Empowering individuals with accurate, culturally relevant health knowledge can drastically improve health outcomes, reduce preventable diseases, and enhance resilience. So what are the strategies that we can use for effective empowerment of communities? The health education must be culturally relevant. And for it to be that relevant to the culture of the target communities, it must use the local languages. It must be in the local languages. It must involve the traditional leaders. The leaders could be women, it could be young men, or the traditional leaders, religious leaders, teachers, and other people who are already trusted within the community to legitimize the messages, the health information. And it must align with religious or cultural values of the communities. Secondly, it must be community-based and participatory. Rather than a top-down approach, communities should be involved in designing and delivering education in a bottom-up approach. I'm going to explain this in the next slide. Through the use of train-the-trainer approach, use of women and youth groups, and use of local facilities as platform for health education. And then for effective empowerment, there is need to leverage of technology. And mobile phones are widely used in Africa now. Health campaigns using mobile phones have been very successful. And some examples include the SMS campaigns to promote vaccinations or HIV testing, video programs in rural areas with no internet, and social media platforms for urban populations. And the last strategy is to focus on women and youth groups. These are very powerful groups in the communities. So any information given to the woman is given to the whole community. And we know that educated women tend to raise healthier children. The youths, when they're fully involved in health education, they are key to changing future behaviors around sexual health, substance abuse, and nutrition. So let me just take you briefly to this top-down approach and then bottom-up approach. In the top, whatever intervention comes to the government, the federal government, and then it is taken down to the state health officers, down to the community health officers, and down to the community leaders and community members. This was how the bed nets were shared, and people receive bed nets, but they're not using the bed nets. But the bottom-up approach means that the community leaders and the community members are involved from the beginning. They are involved from the beginning. They are the ones who will be trained. The community members select their trusted members who will serve as their representative. These people are trained. Once they are trained, they come back to the community to train the community. Then the community together decides on this intervention that is coming in. This is how we're going to do it. This is how we're going to receive it. They take that decision themselves. And when this decision is taken, remember, the training, they're not training themselves, the training comes from the federal level. It comes from the experts. But instead of coming from top down, they start with the community members so that they understand whatever project it is. They understand they are part of the design. They are part of designing the type of education because they know what they will accept and what others, their people would understand. So leveraging on technology for health education. Technology has become a game changer in delivering health education across the continent. From mobile phones to radio-based learning, tech solutions are helping to bridge the gap between health services and out-of-reach populations. For instance, mobile technology and mHealth, Africa, especially Nigeria, has one of the highest cell phone penetration rates in the developing world, even in the rural regions. And this helps to provide an opportunity to deliver vital health information through SMS voice messages, through mobile applications, through rapid SMS. Many countries are using these technologies. And these platforms support family planning, education, prenatal and postnatal care tips, immunization reminders, outbreak alerts, consulting a doctor locally, and getting trusted drugs, etc. So still talking about the tech, social media and radio, there are many social media platforms like WhatsApp, Facebook, Instagram, Twitter, TikTok that are increasingly being used to reach the public with engaging contents on personal hygiene, sexual health, mental well-being, and drug prevention. And community radios, especially in local languages, continue to be powerful and trusted media for mass health communication is limited. Health. Using online trainings of community health workers, especially trained the trainers strategies, allow for scalable health education across remote areas. And right now, telemedicine is growing, especially in Nigeria, with services that connect patients in remote villages to doctors in the urban centers using the basic smartphone or tablets. I will look at local engagement and public education. While technology is very powerful, it simply cannot replace the trust and cultural understanding that comes with community-based approaches, which is one of the strengths of the African society. To be effective, health education must be localized, participatory, as well as inclusive. The World Health Organization and many global funding bodies, many research institutes have now incorporated local engagement of communities for successful implementation of their health intervention strategies. So let's take a case study of onchocerciasis. Onchocerciasis is a disease it's also called river blindness. It is caused by infection with a filarial worm called onchocerciasis volvulus. This onchocerciasis volvulus is transmitted from person to person through the bite of the black flies. The black flies breed in the rivers, fast-flowing rivers. They breed in the fast-flowing rivers. And the black flies need blood meal to lay their eggs. When they take a blood meal, they pick up larvae, we call microfilariae, from the body of somebody who is infected with the filarial worm, onchocerciasis volvulus. And after they have laid their eggs, they need another blood meal to stabilize themselves. And by the time they go for the second blood meal, the microfilariae they had picked up had developed to what we call infective L3 level. So by the time it takes its second blood meal, it's transmitting to the next person this filarial parasite. Now, onchocerciasis, if you look at the picture, that the worm, the female worm, can get as long as 50 centimeters and is tightly coiled, which is why the name is volvulus, onchocerciasis volvulus. And the male is small, 2 to 3 centimeters. They live together in what we call nodule. When it gets into the human being, it causes the connective tissue to form a nodule, to form a home, like a protective home. So they live inside these nodules. And inside the nodules, the adult female gives birth to thousands of microfilariae daily. These adult worms can live up to 10 to 15 years in the body, giving birth. Most other worms lay eggs. These filarial worms give birth. they give birth to millions of microfilariae. Now, these microfilariae, they have limited time to be in the body. They circulate around the entire body, but there is a limited time. They don't stay in the body for up to 12 months. They are circulating in the subcutaneous tissue, waiting for the flies to pick them up so that the life cycle can continue. Once the fly picks them up, then they can develop within the fly and be transmitted. But if they don't get picked up by the fly, once the time gets for them to die, they start dying. And once they start dying, the body reacts, the immune system reacts. And if it's in the eye, it causes blindness. That's why it's called river blindness. Now, when this microfilariae start dying, it causes itching. The itching is the first sign. The itching is different. Once it's onchocerciasis itching, it is quite different. It's continuous. It's continuous. So people who have it, they look for an object. When they are tired of using their fingers to scratch, they look for objects to scratch. And those objects could cut the skin and introduce microorganisms, and then you have serious depigmentations. So if you look at the pictures on the right, the first one is a nodule on the head of a small boy. Then all those skin conditions are what we see in the field, caused by the microfilariae. The other forms don't cause, they're just there, giving birth. But the ones that cause the problems are the microfilariae. So these are other effects: the eyes, corneal opacity, sclerosing, keratitis. All these result in blindness. Then there are other neurological disease conditions caused by onchocerciasis. We have what we call the Nakalanga syndrome, nodding syndrome. The person just keeps nodding. And then we have epilepsy caused by onchocerciasis. Now there are some unexplained physiological effects. Some people were sterile because they were infected with onchocerciasis, and we didn't know that until we started treatments. Once we started treatments, they took ivermectin. The women conceived, the men also. And we said, oh, you mean that this sterility was caused by onchocerciasis? So there are also lymphatic complications of onchocerciasis who have the hanging groin syndrome, hydrocele, lymphedema. I didn't want to put those pictures because they are very terrible. So, so along the line, it became a problem. Onchocerciasis was terrible. So the World Health Organization now started looking at ways to eliminate onchocerciasis. And the first attempt was to get rid of the flies. They were doing area spraying, but these flies can fly for up to 100 kilometers non-stop. So if you clear one area, they come back. So they found out that removing the flies was pointless. So they decided there was a drug that was discovered, Ivermectin. Ivermectin is able to kill the microfilariae, kill the ones inside the adult ones, so that the person is free of microfilariae. The flies can bite, but they cannot pick up the microfilariae to transmit. You understand? So ivermectin became the drug of choice, and ivermectin is safe. It can be given one oral dose once for a year or for a period of 6 months. So it became necessary that in a community that is endemic for onchocerciasis, everybody must be treated. And EPOC now, they're the ones that designed this community-directed intervention process. The first times they tried treatment, they brought in drugs, they went to the communities, they gave the communities, some took something intake. They found they could not get sufficient coverage. So they came back with this community-driven intervention process. In the community-driven intervention process, the community members were educated. They were told, first of all, they were made to select their community-directed distributor, CDD. They had to select somebody that they trust, or people that they trust, who can come and give them the right information. So the CDDs were trained on how to, about the disease, about the symptoms of the disease, about how to give the drugs, and possible after effects of the drugs. So they were able to relate to the villages. In community-directed process, the villagers would decide, we want our drugs in October because it is dry season. So we want our drugs. The CDD would decide how many people are available in the community. So he would note the number of drugs that they are going to ask for. He would ask for the drug to the local health facility. Local health facility takes to the state takes to the local to the federal government. Then the drugs come down from state to the local health facility, and the CDDs will be informed by the local health person that the drugs have arrived. The CDDs will go pick the drugs. Once they get the drugs, they will meet with the community to decide, how are we going to share our drugs? Are we going to do house by house sharing of these drugs? Or are we going to converge in a place, maybe the health center, everybody comes to the health center on a particular day at a particular time? They decide. They decide, and with this method, this encourages ownership of the process. And we forgot almost 100% coverage and therapeutic coverage. So this map shows, the one on the left shows the African countries that are endemic for onchocerciasis, and those ones that are endemic are colored in red, and the other pink color are the ones with endemic for lymphatic filariasis. And so you find that in many countries, lymphatic filariasis and onchocerciasis coexist. The next map on my right shows the efforts that has been done, the elimination process. This has been going on for almost 20-something years. This mass drug administration has been ongoing. And I forgot to mention that onchocerciasis was also present in the Americas. Now, but by 2013, between 2013 and 2016, Colombia, Ecuador, Mexico, and Guatemala had all been verified to be free of onchocerciasis by WHO. This group used the same process, and they decided that while the African countries were doing once annually, they started twice annually. And before you knew it, onchocerciasis was eliminated in these countries. So the importance of local engagement in health education. So while technology provides the tools, local engagement ensures that health education is relevant, it's culturally appropriate, as well as sustainable in the following ways. Local engagement ensures community ownership and participation. Empowering communities means involving them actively in identifying their health challenges and designing solutions. This fosters a sense of ownership, making programs more effective and sustainable. Community health committees and local leaders, traditional chiefs, religious leaders, and elders are vital in bridging the gap between healthcare providers and the community, ensuring programs reflect local needs and preferences. This community-directed approach resulted in the elimination of onchocerciasis in the region of Americas, Colombia 2013, Ecuador 2014, Mexico 2015, Guatemala 2016, and Africa, Niger 2025. Cultural relevance. Health education and local engagement ensures that information is presented in a way that respects the local beliefs, customs, and practices, thus increasing the likelihood of acceptance and behavioral change. Examples: local customs and beliefs can interfere with geographical coverage of the implementation of certain health interventions. For example, polio vaccinations in some parts of Nigeria well, this was viewed with mistrust many years back. And every year, among the African countries, Nigeria was the only one that still reported polio. But with local engagements, this problem has declined significantly. Now, in some parts of Southeast Nigeria, some years back, bloody urine, which was as a result of heavy infection with the disease, schistosomiasis, also known as snail fever, was culturally accepted as a sign of coming of age for young boys. So this, however, has been clarified from effective local engagements and health education.